The last talk for today is by Dr. Parul ICHHPUJANI, and she'll be giving a few lessons and tips on neurophthalmic disorders. Dr. Parul, please.
So, good evening, everyone. I'm basically a glaucoma person, but over past 2-3 years, I've started doing neuroophthalmology, and I've learned some lessons along the way. So, sharing those in the form of cases with you. It's not moving. Sorry. So this is a young female who presented with left-sided grade 3 facial nerve palsy with extreme headache, and rest of the examination was unremarkable. She had grade 2 disc edema, and she was recently diagnosed to have PCOD, for which she was not taking any oral contraceptive pills. She was obese, and she was diagnosed to be IIH, and the treatment for IOH and Bell's palsy was instituted. The imaging showed that there was a pituitary gland flattening, which corroborated with the findings of IIH. But despite the treatment that was given to her, even over a period of 1 year, the disc edema did not resolve. And that's something which is very surprising. The patient tried to reduce weight, and despite treatment, the edema was almost stable. So there is something that needs to be thought about when there is prolonged optic nerve edema despite the treatment being given, and the differentials for this scenario included neurosarcoidosis, brucellosis, or Lyme's disease. Neurosarcoidosis was ruled out with normal ACE levels. Her IgM brucella was fine, but she showed an IgM Borrelia which was positive for Lyme's disease. Now, I practice in Chandigarh, and Chandigarh and Punjab belt as such is not an active belt where Lyme's disease is endemic. So this is something which was offbeat. So the test was repeated, and on the repeat test as well, she turned out to be positive. Although the most diagnostic test is PCR, but she couldn't afford but 2 tests repeatedly showing an elevated IgM Borrelia warranted treatment, and so she was started on doxycycline for 21 days, and that led to the resolution of edema. So she was ultimately diagnosed to have secondary intracranial hypertension with Bell's palsy due to Lyme's neuroborreliosis. Now, the important thing is that sometimes we have to think outside the box when the disease is not responding to treatment as you would expect it to be. And as clinicians, we must be aware of things that can befit a scenario, even if they are not endemic or expected in the region of your practice. Going over to case 2, a 15-year-old female who presented with marked diminution of vision, hand motions close to face and right eye, and PL and PR in the left eye. She was wheelchair bound, young girl, happy, just 2 days prior to presenting to us. She had a very typical blind stare and listless, but the stare would keep coming and going, and it primarily I thought probably she was malingering because that was the time closer to exams. But when we did the imaging, we found that she had bulky bilateral optic nerve complex suggestive of an optic neuritis, and subtle meningeal enhancement was also noted along the midbrain surface. So something was definitely wrong. She was not able to hold her head properly after 2 days of admission. So MRI cervical spine was done, and that revealed transverse myelitis. So over a period of past 1 or 2 years, I've realized that NMO spectrum diseases and MOG diseases are much more common than what we expect in our routine population. So this girl turned out to be positive for anti-aquaporin 4 NMO IgG, and she was started on treatment. So despite intravenous methylprednisolone being given for 7 days, the vision did not really improve that much. So she was started on plasma exchange cycles with FFPs, and that responded well, and the vision started getting back. So her uncorrected visual acuity improved to counting finger 2.5 meters and 2 meters in the other eye. So the lesson learned was that early intervention and multidisciplinary collaboration with other specialties like transfusion medicine is important to institute the right treatment. Sometimes we just go on giving steroids in such patients thinking that steroids are eventually going to do wonders, but if we pass that window wherein plasma exchange or rituximab or any other immunomodulation that you plan to give, if we pass a particular window, the visual acuity does not improve to the range it would have improved otherwise. Going on to case 3, a 16-year-old female presented with fever, headache, vomiting, and focal seizures. The neurological examination revealed meningeal irritation. CSF analysis was corroborative of tuberculosis. She was started on ATT, and after 2 days of starting ATT, she developed a sudden drop in vision. Now, ethambutol, which we think is notorious for causing vision, does not lead to a such sharp drop in vision just in 2 days. So her vision had dropped to counting finger 1 meters. She had ill-sustained pupillary reaction. We can see that the motility was limited, and the VEP also showed a decreased amplitude in both the eyes. On doing her imaging, we found that she had enhancing lesions in the interpeduncular region and the supraciliar cisterns, which were suggestive of opticochiasmatic erycanoiditis. Now, this is something which was very subtle in this case, but had to be picked up because we were so sure that there is something which is majorly wrong. It cannot be the drugs that can cause vision. So we had to sit with the radiologist and see and look at each of these scans properly to pick this out. She was given IV methylpred for 5 days, but there was no improvement. There is no standard of care which has been established for OCA. The treatment options that have been tried are intrathecal hyaluronidase, infliximab, and thalidomide. The patient could not afford infliximab, and so she was given injection hyaluronidase, the one that we used for cataract surgery, 1500 units given intrathecally weekly for 10 weeks, and she responded, and there was some improvement in vision. So that's something that we need to keep in mind. We need to look at each of the scans properly when we suspect that the treatment is not working the way it should. So contrast enhanced MRI is needed for patients who are taking treatment for TB meningitis, for demonstrating OCA and subtle tuberculomas that can be missed, and treatment can be given accordingly. So sometimes you have these isolated cases and they have these variable success, but you must try each and every possible entity to do the justice to them. So neuroimaging is the key, and you need to look at each scan and maybe learn over a period of time yourself which a radiologist can miss. So case 4 is of a 25-year-old female who had frequent severe headaches resulting in transient obscuration of vision. These headaches were worse on waking up, and she also had tinnitus. She had disc edema. Although there was nothing which was correlating, when I looked at the forehead of the patient and could see these acne, I asked the drugs that she was taking, and she said she was taking oral doxy, topical Clinda, and isotretinoin. Now, isotretinoin is notorious for causing idiopathic intracranial hypertension, and when this drug was stopped, the headache and disc edema resolved in 3 weeks. So it's a good idea to focus and dig out the drug history that the patient is taking, and sometimes it pays to be observant beyond the eyes also. Last case, young child, 7-year-old male, decreased vision with headache. The best corrected visual acuity was counting finger 2 meters. There is grade 2 disc edema, and the patient was strongly positive for anti-MOG IgG antibodies. The imaging showed bilateral symmetrical white matter lesions in parietal lobes and the left occipital lobe, and there was a diffusion restriction in intraorbital part of the optic nerve, suggestive of optic neuritis. Received 5 days of IVMP followed by oral steroids. The disc edema resolved and the vision improved to 636. But 8 weeks later, the child had fever and the vision dropped from 636 to 460. Now, the child was even continuing at this time on oral steroids. So there was a positive UTOFs phenomenon. The vision blurring was associated with fever spikes. So we had to take a pediatric opinion. Is it treatment failure or an inadequate response that, but the treatment is working? So do we need to supplement or step up on the steroids that the patient is taking? Or is the disease activity still continuing and steroids are absolutely not working? So the answer, the pediatricians were also not very sure. They wanted an objective finding to, switch to an alternative treatment. So the answer came from VEP. The VEP of this patient from baseline to 8 weeks later showed that there were some leads which were repeatedly not picking up the response, and there were some parameters now which had dropped and they were having an exclamatory sign along with it. So there was definitely a drop which was picked up by electrophysiology, and the patient was given buffer therapy of IV immunoglobulins 2 grams per kg given over 60 hours, and the vision, the best corrected vision, improved to 6.9 and 6.12. So VP progressively as a prognosticating factor can sometimes give us an answer whether we need to step up or give an alternative treatment. So we need to monitor the disease progression, assess recovery or relapse, and therefore an electrophysiology is very, very important. So to conclude, eye should be considered as a window to the brain. It is very, very imperative that we take good comprehensive history, paying focus on the drugs that the patient is already taking. Understanding the nuances of visual pathway makes us understand which area to target. Interdisciplinary collaboration is a must when we talk of neuro-ophthalmology, and there is a holistic approach to treatment. Visual rehabilitation needs to be done for all these patients, and they have to be followed up for a very long period of time. Thank you so much. And with this, we come to the conclusion of the session. I thank all of you for attending and sitting through. So you've been a very precious audience, because when we came in, there was just us, the speakers. Thank you for everybody who's hung around. And I'm extremely thankful for all the esteemed speakers, because they are stalwarts in their own fields, and they have taken extra time to prepare slides of the lessons that they have learned over their years, and they've been very kind enough to share it with us all. So thank you, everybody, for being here and making this session a success.